Primary angle closure glaucoma. Primary angle closure glaucoma with pupillary block. Acute congestive glaucoma. Sudden rise of intraocular pressure due to partial or complete obstruction of aqueous outflow at the angle by the iris in a predisposed patient with narrow anterior chamber. Race, Eskimo, and Asians. Gender, more in women, where the female to male ratio is 3:1. Age, 55 to 65 years. Family history is positive. Predisposing factors of acute congestive glaucoma. Local factors. Narrow angle, shallow anterior chamber as in. Hypermetrope eyes with anterior iris surface close to trabecular meshwork. Aging, progressive increase in lens thickness, age above 40 years. Females, emotional distress and vasomotor instability. Shallower anterior chamber depth less than 2.5 mm predisposes to primary angle closure glaucoma. General factors. Nervous type personality. Vasomotor instability results in ciliary body congestion with forward displacement of the iris lens diaphragm, leading to shallow anterior chamber. Winter months. Low ambient light levels result in pupillary dilatation. Precipitating factors of acute congestive glaucoma. Pupillary dilatation results in angle closure. Mydriatics, as systemic atropine-like drugs. Excitement, parasympathetic stimulation. Prolonged stay in the dark, and prone position. Pathogenesis of angle closure. Iris bombay. In narrow anterior chamber eyes, the iris is tightly opposed against the lens. Relative pupillary block. Aqueous humor is trapped in posterior chamber. When the iris is mid-dilated, the iris base becomes relaxed and pushed forwards, leading to angle closure. Plateau iris. This represents primary angle closure glaucoma without pupillary block. Ciliary processes are anteriorly positioned, resulting in pushing peripheral iris forwards. With pupillary dilatation, peripheral iris heaps up and obstructs trabecular meshwork. Ocular findings in acute congestive glaucoma. Hyperopia, crowded anterior segment. Corneal epithelial edema. Shallow anterior chamber. Iris bombay with functional pupillary block. Vertically dilated fixed pupil. Peripheral anterior synechias with recurrent attacks. Optic disc edema. Stigmata of prior attack. Segmental iris atrophy. Focal ischemic iris necrosis. Dilated irregular pupil. Sphincter and dilator muscle necrosis. Glaucomflecken. Focal anterior lens epithelial necrosis. Papilledema. Acute blockage of exoplasmic flow due to laminar distortion. Central retinal vein occlusion. Secondary angle closure glaucoma. Secondary angle closure glaucoma with pupillary block. Chronic primary angle closure is caused by persistent flat chamber, as in wound leak, post-filtering surgery. Inflammation with posterior synechia and iris bombay. Seclusion of pupil by 360 degrees posterior synechias. Occlusion of pupil by pupillary membrane. Phacomorphic glaucoma. Lens enlargement in elderly, anterior lens dislocation, and microsphere phakia. Absence or non-patent iridotomy or iridectomy, iridovitreal synechia. Anterior displacement of lens iris diaphragm by intraocular tumors, exudative retinal detachment, post-heavy scatter laser photocoagulation, retinopathy of prematurity, and persistent hyperplastic primary vitreous. Cysts, anterior chamber or iris, traumatic implantation cyst. Malignant glaucoma, aqueous misdirection. Post-operative uniform flattening of central and peripheral anterior chamber with high intraocular pressure. This is caused by ocular surgery, shallow anterior chamber, chronic angle closure with peripheral anterior synechia, and myopic drops. In malignant glaucoma, the following take place. Anterior rotation of ciliary body and posterior misdirection of aqueous. Relative block to aqueous movement at lens equator, vitreous face, and ciliary processes. Flat anterior chamber. Anterior displacement of lens IOL or vitreous face. Anterior pulling mechanisms. Angle closed by permanent peripheral anterior synechia. In repeated acute congestive glaucoma, repeated anterior uveitis, neovascularization of the angle, epithelialization or endothelialization of the angle. Neovascular glaucoma, rubiosis iridis. This is a form of proliferative glaucoma with fibrovascular membrane growth on the angle and the iris. Pathogenesis. Angiogenetic factors produced by ischemic retina, tumors, and inflammation. Abnormal vessels on normally avascular anterior surface of iris lack thick collagen coat of normal iris vessels. Transparent fibrovascular membrane flattens anterior iris surface. Myofibroblasts provide motive force for angle closure and ectropion iridis. Neovascular glaucoma is caused by inflammatory conditions as anterior uveitis and intraocular inflammation. Proliferative vascular conditions causing neovascular glaucoma include proliferative diabetic retinopathy, ischemic central retinal vein occlusion, ischemic oculopathy as carotid occlusion, pulseless disease, chronic retinal detachment, Coats disease, Norris disease, retinopathy of prematurity, Chiari artery occlusion with retinal infarct, postoperative anterior segment ischemia or necrosis after retinal or strabismus surgery, sickle cell hemoglobinopathy. Other causes of neovascular glaucoma include tumors, retinoblastoma, 50% of unilateral cases, malignant melanoma, primary and secondary closed-angle glaucoma, post-traumatic vitreous hemorrhage, secondary proliferative glaucomas, epithelial downgrowth. Contact inhibition by healthy endothelium may inhibit endothelial downgrowth. Iridocorneal endothelial syndrome, unilateral glaucoma in young to middle-aged women. Pathogenesis, corneal endothelial proliferation with thickening and proliferation of Descemet's membrane-like structure growing on surface of trabecular meshwork and iris, with associated secondary iris abnormalities. Types: Cogan-Reese, iris-nevus syndrome. There is flattening and effacement of iris stroma, endothelialization of anterior chamber angle and iris surface, pigmented iris nodules. Chandler syndrome, corneal edema at low intraocular pressure. Essential iris atrophy, proliferating endothelium produces synechia in an open angle. Chorectopia, ectropion uvea, tractional iris holes, and endothelial dystrophy are met. Iridoschisis. This is a condition associated with breakdown of iris stroma. It is caused by aging in the 7th decade, trauma, or peripheral anterior synechia, which is rare. Low anterior iris stroma separates from deep layers. The pupil is round and reactive. Glaucoma occurs in 50% of cases due to peripheral anterior synechia.